All right, we can get started. Hi, everyone. My name is Anna Cash. I'm a training and technical assistant specialist with NCAL. I'm going to be helping you all out behind the scenes today. This is trauma-informed practices for MDTs. We're going to be covering some really great stuff today, and hopefully it will be a great discussion as well. All right, just some welcome and introductions. I said who I am. We do have a bunch of folks from the National Center joining us today, familiar faces, and I know a lot of you already know each other as well as you work pretty closely. Next slide, please. All right, as always, we have our disclaimer here that the opinions, findings, conclusions, and recommendations expressed in these materials are not necessarily representative of the official position or policies of the DOJ. You've seen this before. Next slide. And some housekeeping items. Again, you all are super experts at Zoom, but just remember to mute if you're not speaking to prevent any feedback. Feel free to use the chat function to engage with the content. And I think everyone has their name displayed correctly. I'm not seeing any issues there, but just make sure you have the name that you would like on your Zoom. Feel free to raise your hand if you have a comment or a question. There'll be time for questions at the end, but I'm sure that if there's anything kind of pressing or you want to get some more information about a specific section, chat or raise your hand. And we won't be having breakout rooms today, so that's not super relevant. And of course, if you have any tech issues, the best way to reach me is via chat. I'll be here during this time to help you all out. And I know that we are also having, I'm having some issues with the polls. So there will be a poll question that we might have to use the chat function for, which is not a big deal. It's a very easy question. It's about who you represent professionally. So you all should know the answer to that. So no worries about that, but I'll let you know if that does change at all. And I'm going to turn it over to our wonderful presenter. Next slide.
Hi, everyone. I'm Caitlin Snow. It's fun to be here today. I'm going to talk about trauma. I am technically not so savvy, so you're going to hear me saying a lot next slide because I couldn't figure out how to present from my computer. So my apologies for that disruption. I am a geriatric psychiatrist. I'm in private practice, but prior to switching to private practice, I did a lot of work in the hospital, both doing a lot of consultations of people who were hospitalized for medical reasons, and then also on the inpatient psychiatry unit, working with older adults who were psychiatrically hospitalized. And then I also did some work with the palliative care service and geriatrics division of medicine. And then I switched into private practice, and I see people aged 18 to, actually over 100. But I specialize in seeing older adults, and I see them both in my office and then in a number of assisted care facilities, so across settings. And one of my favorite parts of my job is that I work on one of the E-MDT teams in Queens, which is an incredibly, I think it's one of the most diverse places in the United States. And so a lot of the cases we see are really interesting, and I've learned a tremendous amount from all of the people. So it's a highlight for me to get to be here today, especially with people from all over the country working in this area, because it is one of my, passions and main interests. All right, next slide. Learning objectives. After attending the webinar, you'll be better able to identify trauma and its impact on older adults physically and psychologically. I too identify different disciplines' response to trauma and its impact on the E-MDT work, and also identify promising trauma-informed practices, including the least restrictive options such as trauma, CBT for trauma. Next slide. Participant poll, and I don't know, Anna, if you want to jump in.
Yeah. So I'm still having some issues with our Zoom polling. So I'm going to ask you all to chat using the chat box. You'll find that at the bottom of your screen. I believe it just says chat. And everyone, if you could drop in which best reflects your work, some examples that are kind of pretty universal for the folks that we're working with is going to be social work, law enforcement, APS, medical services, mental health services, legal services, and senior housing. So if any of those kind of resonate with you as your professional background, feel free to drop that in the chat. And if not, you can throw in your either job title or organization, whatever you would like. This is just to kind of gauge who we have in the room, what where people are coming from, and what background they have with regards to our topic today. So we'll give it like a minute for that. This can be an ongoing thing as well. Caitlin, if you want to keep going and just kind of, we'll see what we get in the chat as well.
All right, sure. I'll cruise on and look forward to hearing where you're all from. Okay, so I wanted to start with a clinical case of a patient who I see here in my office. She's actually currently hospitalized. She is I'm going to call her Rachel. She's a 93-year-old woman, a Holocaust survivor. At the time I first started seeing her at the end of 2019, she was recently widowed and had relocated to New York City from Philadelphia to live with her adult daughter and grandson and her adult daughter's husband. During the Holocaust, she was sent to Kindertransport, which was a rescue effort to get kids out of Nazi-controlled territories. And so she was sent to them at age 9, while her parents stayed back in Germany with a younger sibling who had a birth defect, and her parents and younger sibling didn't survive. She was brought to the UK, where she was in a kinder camp, and she later moved to the United States. She worked as a successful artist and was married and widowed 3 times. She actually was the person to discover in each of those circumstances when her husband's died, she was the one to discover the body. So each of those was a fairly traumatic encounter with their death. She has close relationships with her daughter, son-in-law, and grandson. In 2019, she was hospitalized for 5 days in New York, initially for confusion and a little bit of agitation. They did an extensive medical workup, which is unrevealing with the exception of a urinary tract infection. They gave her antibiotics. She had an allergic reaction to them, and the hospital course was complicated by delirium, so acute confusional state that later resolved. She reported that during the hospitalization, she felt scared, vulnerable, and helpless. She said, "Things happen and you have to be lucky to survive." She made statements that she wanted to die, and how long can I stand this? So her treatment team there consulted Psychiatry, and they started her on an antidepressant. After discharge from the hospital, she had a severe and debilitating emergence of post-traumatic stress disorder symptoms. She had intrusive memories of a young girl who had wet the bed at the kinder camp that she was in Great Britain, and this girl was made fun of. She developed poor sleep due to ruminative concerns that she herself would wet her bed, and she would sit on the toilet for prolonged periods throughout the night, having panic attacks that were complicated by aerophagia. Aerophagia is when instead of breathing air, you're swallowing air, and so the air doesn't go into your lungs, it goes into your stomach, and you can become really distended, and it's quite uncomfortable and painful. When I saw her, she reported feeling that she was never settled, everything is temporary. She endorsed survivor guilt, anticipatory anxiety about her physical and cognitive decline, social withdrawal, feeling that she was suffocating, depression, and suicidal ideation. Next slide. So I guess back to Rachel for a second. She actually, it's a fairly dramatic case, but a case that, really does involve a lot of the main tenets of, thinking about trauma in older adults. So I'm going to refer back to her a lot throughout this. And another thing I will refer to a lot is a wonderful book called The Body Keeps the Score about trauma. So I have a couple of quotes from that book throughout, and this is the first one. We have learned that trauma is not just an event that took place sometime in the past. It is also the imprint left by that experience on the mind, body, brain, and body. This imprint has ongoing consequences for how the human organism manages to survive in the present. Trauma results in a fundamental reorganization of the way the mind and brain manage perceptions. It changes not only how we think and what we think about, but also our very capacity to think. Next slide. So this refers to the concept of trauma, which I'm guessing some of you have encountered in the past. This is SAMHSA's concept of trauma, but I think it's a very useful framework for thinking about it. So it's called the 3 E's. So individual trauma results from an event, series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So the 3 E's are event, that are experienced by the individual and has lasting effects. So aging and trauma. Research is very limited. So most randomized controlled trials of psychotherapy for trauma do not include older adults or include them in insufficient numbers to make any age comparisons. And none of the randomized controlled trials have tested the efficacy of the best studied evidence-based psychotherapies for post-traumatic stress disorder or trauma in older trauma survivors. So it isn't to say that these evidence-based psychotherapies couldn't be effective for older adults, they just haven't specifically been studied in this population. We do know, however, that 50 to 90% of adults in the United States have been exposed to at least one traumatic event, and that exposure to multiple traumatic events is common. And traumas for our older adult population, traumas often occurred when there was limited understanding of trauma or treatment options. So older adults who were abused or exposed to trauma at earlier stages often never received help to process those traumatic experiences. And there's a fairly considerable body of emerging literature that suggests that a history of trauma increases the risk of abuse. So specific to our population, many of these older adults who are victims of elder abuse also have a history of trauma and often have a history of multiple traumatic events throughout their lifetime. Next slide. So aging and trauma. So an interesting thing about trauma, what we've noted with trauma in older adults is that symptoms of trauma can evolve or change after long symptom-free periods, can reemerge after symptom-free periods, and can emerge for the first time during older adulthood, long after a traumatic event. So Rachel, who I talked about, she had a big time history of trauma that she talked about regularly with, friends and family. But this one episode of, being at the kinder camp and having a girl who she knew wet the bed and be made fun of, that memory had not been spoken about, had not been thought of until she had this hospitalization in later life. And all of a sudden it became the focus of all of her trauma and the focus of her own toileting and physical issues. Symptoms of trauma emerging in older adulthood can be more extreme, and late life transitions can often trigger trauma symptoms. So this can be retirement, relocation or a move, health changes and physical limitations, changing familial roles, bereavement, loss of independence. And again, in the case of Rachel, she had a tremendous number of life transitions that all happened at the same time. And this isn't uncommon. Often somebody will lose a spouse and at the same time, they will have to move as a result of this. They themselves will decline physically. Some of the supports they were getting from their spouse, they'll now have to depend on new people for. They'll have to move in with family members, and often that's where we see elder abuse kind of emerge. So late life transitions, as was the case with Rachel, but with many of the people that we see, are big triggers for trauma symptoms to emerge or reemerge or evolve. I'll go into this in a second, but coping strategies for older adults also aren't as available. So there are fewer social opportunities. Often they have limited access, so they're not able to drive or get places. And then there are also physical limitations. So many people who historically would cope by exercising or walking or being outside don't have access to those coping strategies. So I'm going to march through the signs and symptoms of, really these are PTSD. And one thing I want to note, which I'm sure you have all heard about, but not all trauma leads to PTSD. So a tremendous number of our people have experienced trauma and have lasting effects from that trauma, but wouldn't meet criteria for PTSD. The prevalence of older adults who are diagnosed with PTSD is actually quite low and lower than mixed age adults. So it's 1.5 to 4% of the population actually meet criteria for PTSD, according to the DSM, or Diagnostic and Statistical Manual of Mental Disorders. The difference is that for diagnosis of PTSD, the trauma has to be of the most severe kind. You have to have exposure to actual or threatened death, serious injury, or sexual violence. And then you have to meet criteria, signs and symptoms of trauma in each of these 4 categories. So intrusion symptoms, where the traumatic event forces its way into a person's current experience; avoidance, negative alterations in cognition and mood; and arousal and reactivity. And so, while not all trauma leads to PTSD, many of the symptoms of people who have been traumatized are symptoms of PTSD. Okay, next slide. Intrusion symptoms. So these are memories, repeated involuntary, intrusive, and distressing memories of the trauma; dreams; dissociative reactions. I think this is what most people think of first when they think of PTSD, and these are flashbacks. So this is experiences in when the person feels or acts as if the traumatic event was happening again right now, and how real the experience feels can vary tremendously. And then psychological distress and physiological reactions on exposure to cues that symbolize or resemble some aspect of the trauma. Next slide. Avoidance. So avoidance is extremely common in trauma. So there's a persistent avoidance of stimuli associated with the trauma, and these can be internal stimuli like distressing memories, thoughts, or feelings, or external reminders of the trauma. And for older adults, in an attempt to avoid triggering sensations and experiences, older people can become more withdrawn and isolated, which can contribute to comorbidities such as depression, anxiety, and health issues as well. Negative alterations in cognitions or mood. And just by the title, I think all of you, because you work so extensively with older adults, would recognize this, but the effects of trauma on an older person can often be confused with or masked by physical ailments and cognitive impairments common in older life. So trauma alone in a mixed age population can cause alterations in cognitions and mood. So that's something that becomes increasingly difficult to diagnose and parse out when you have older people who, many of them as part of their aging will simultaneously or independently develop cognitive issues and mood changes. But these negative alterations in cognitions and mood include that the person can't remember some important aspects of the traumatic event. There are negative beliefs or expectations about oneself, others, or the world that are both persistent and exaggerated. So these are beliefs like I'm a bad person or other people can't be trusted. An example of this in the case of Rachel was, bad things happen and you have to be lucky to survive. Distorted thoughts about the cause or consequences of the trauma. Again, Rachel, very much, said this she's a very attractive woman. And she said I was able to go to kinder transport because I was attractive. My parents and brother died because he was disabled. So she very much believed that, and it contributed tremendously to her survivor guilt and her negative feelings about her own attractiveness and, what it gave her and, the expense to others. A persistent negative emotional state of some kind. So this can include fear, horror, anger, guilt, shame, greatly decreased interest and participation in significant activities, and persistently being unable to experience positive emotions like happiness, satisfaction, or love. Next slide. Arousal and reactivity. And again, these are many of the symptoms that you may expect to see in an older person generally with normal aging, or in an older person with a neurocognitive disorder or dementia. But irritability or angry outbursts, reckless or self-destructive behavior, hypervigilance, exaggerated startle response, impaired concentration, and impaired sleep. And just to note, an example of this, how similar they are with, when you look at how people's sleep looks over time on sleep studies, young people have these, beautiful curves of REM and non-REM sleep. And the sleep architecture in older adults is very fractured and looks more like a, building skyline. And so, trauma further impairs sleep, but, is hard to differentiate between just normal changes in aging and the effects of trauma. Next slide. Again, from The Body Keeps the Score, long after a traumatic experience is over, it may be reactivated at the slightest hint of danger and mobilize disturbed brain circuits and secrete massive amounts of stress hormones. This precipitates unpleasant emotions, intense physical sensations, and impulsive and aggressive actions. These post-traumatic reactions feel incomprehensible and overwhelming. Feeling out of control, survivors of trauma often begin to fear that they are damaged to the core and beyond redemption. So over time, the chronic stress that people experience as a result of trauma can cause chronic physical, cognitive, and mental health issues. It's been described, which I think is a wonderful description of it, as accelerated aging with worse health across organ systems. There's an early occurrence of medical problems, premature signs of biological aging, and premature mortality. And these effects, as I've mentioned, of trauma can be confused with normative cognitive declines. So as a result, for many older trauma survivors, the root cause of their difficulties in behavior is often not understood, diagnosed, or addressed. But you can really see, as these lists, in each of these areas, there has been a robust body of literature that's found an association between trauma and early onset and more severe issues with all of these in all of these different domains. And even worse is treatment response, treatment access and treatment response for each of these conditions has also been documented to be impaired. So, it seems like they're not only having this accelerated aging, but the issues that they're experiencing are more difficult to both diagnose and treat for a number of reasons that we'll get into a bit. So barriers to diagnosis and treatment. So older adults tend to underreport trauma. One, they may not recognize the association of trauma and health. So if they go to their primary care physician, the primary care physician is asking, to take a deep breath and, do you have any chest pain and any stomach pain? How are your, how's your urination? And they're not recognizing that it would be important for this physician to recognize that trauma is impacting their physical health. Often older adults fear stigma of having a mental health condition. And, one of the very important things, and somewhere where I do think E-MDT coordinators can intervene, is that the actual act of revealing a trauma history in a non-therapeutic or unsafe setting can trigger PTSD symptoms and trauma symptoms. So if an older adult is in the emergency room and asked about their history and, in a position where they're having to say, I have a history of PTSD, I'm a veteran, and ask further questions, that in and of itself, the very act of talking about the trauma in a situation that doesn't feel entirely safe can cause significant PTSD symptoms. So there's an avoidance on the part of the person who's been traumatized from interacting in that way with healthcare professionals. Healthcare providers, go back for 1 second. Healthcare providers under-recognize and misdiagnose signs and symptoms of trauma in older adults. So as we mentioned, trauma symptoms can present differently in older adults or be masked by other conditions. So even for somebody who's well-equipped to make diagnoses and very informed about trauma and well-intentioned, they can have difficulty diagnosing. Older adults are more likely to report physical concerns or pain, sleep issues, GI issues, and cognitive difficulties than they are to report on mental health difficulties. And often older adults tend to go to their primary care physician, even for mental health issues, rather than seek out mental health services. And then it's the case in New York, and my guess is it's the case everywhere. There's limited trauma-informed care, period. So it's very hard to access it. All right, next slide. So the effects of an aging brain, this is normative changes on the aging brain. And I think it's a useful image because the effects of an aging brain are very multi-directional. So there are some things that tend to decline as natural courses of structural changes of an aging brain, and there are other things that don't decline or even improve or just change. So in general, mental processing slows. Multitasking becomes more difficult. Prospective memory declines. So this is memory about what you have to do in the future. So I have to return my library book on Friday, planning for that and executing on that. Trouble processing highly arousing experiences. So clearly this is important for trauma-informed care and psychotherapies for trauma, that an older brain has more trouble processing these highly arousing experiences. The ability to store new vocabulary increases, the ability to store new concepts increases. Temporal memory typically holds. This is not the case in dementia or neurocognitive disorders, but temporal memory, which is what both recent remote memory, what I had for lunch today, and also, where I grew up and, who was in my family and what my first grade teacher was named. And there's also something that's interesting. It's not entirely related to this, but it's called the positivity effect. And there's more focus on positive aspects of life as people get older. And this has been, this positivity effect has been shown repeatedly over time. But older adults tend to focus on, attend more to positive information. So I used to lecture about financial decision-making in an aging brain. And one of the things is when they would do studies of older adults who were playing computer games where they had to do some betting and take some risks, older adults tended to have a much greater reaction to positive things, so minor wins, and that would cause them to take greater risks and be a little bit more impulsive, and would have a much lower intensity signal of reaction to losses. Whereas a mixed age population or younger people tended to respond in a much greater way to negative information, the losses, than they did to the gains. So it's just interesting. I don't know if it, necessarily has to do with trauma, but it's an interesting aspect of an older brain. So trauma-informed care for practitioners. My guess is you've seen and heard a lot of this. I think it's, useful really, especially with our population, but really with anyone. I think they're useful tips to start an interaction because I think many people, and especially now, many people have experienced some form of trauma. But general strategies include being attentive, helping people feel in control, listening and validating the experience of memories related to the painful traumatic events, focusing on strengths, resilience, and then also always be aware of the environment and take steps to reduce distress increasing situations. So, for a veteran, a loud emergency room may be very distressing. Asking about it, saying the noise seems very distracting. Would you prefer to go into a quieter space? Always, if possible, it's, helpful to involve families and caregivers when appropriate. You want to make sure that it is appropriate because some people won't, and we know this very much in our, E-MDT work. Often family members are, alleged abusers. And so we have to be very cautious about this. But when they can be supportive, I think another big role for, E-MDT coordinators is to help educate them because we're going to be having small interactions. And so, as many people as we can help to educate so that they can then have the direct contact is, going to be useful in, providing trauma-informed care because it really is a system of care. Okay, next slide. So the big thing in trauma-informed care is committing to safety and creating a safe environment. Again, a quote from The Body Keeps the Score. Being able to feel safe with other people is probably the single most important aspect of mental health. Safe connections are fundamental to meaningful and satisfying lives. And I think that's true generally, but definitely true for individuals who have experienced trauma. So I want to focus a little bit and highlight some of the trauma-focused therapies that do exist. And again, unfortunately, most of them haven't had an evidence base in older adults specifically, just because they haven't been studied, but they have been used to varying degrees, and I'll talk about that. So the three main ones are cognitive behavior therapy, exposure-based therapies, and then EMDR. So first, trauma-focused CBT, there is a robust evidence base behind this that it's safe and effective. So what is cognitive behavior therapy? The cognitive component of it is identifying and challenging automatic negative beliefs. And then the behavioral component of it is using thought experiments and exercises to replace them with more objective, realistic thoughts. And then additional components include psychoeducation, coping skills, relaxation exercises, and protocols vary tremendously. The best studied CBT for trauma psychotherapy is called cognitive processing therapy. And, the essential components are, you have the trauma victim write an account about the experience of the traumatic event. And then with the therapist, they examine the beliefs and feelings, challenge maladaptive thoughts and overgeneralized beliefs about safety, trust, power, control, and intimacy. Next slide. So this is, I just wanted to show you a CBT thought record. And I think, everyone who's worked with older adults, especially those with any sort of cognitive issues, would see this and say, there's no way they're doing it. And that often is the case. So I think it's a good framework to march through yourself to know how it works, but very much, in the actual work of therapists and, when you're thinking about what to recommend to other people who are directly working with trauma victims, you'll know that you should liberally do modifications so that it's not just a source of frustration and somebody feeling defeated. But I'll walk through this with you, just one that I did with Rachel, the case study in this example. So when she moved into her daughter's apartment, the shower was, one of these, it was like one of these old New York City apartments that had, 2 shower heads and 3 different dials that you had to do, and was exceedingly complicated. And so she had, a resurgence of trauma symptoms because she was in there in her towel looking at this thinking, and so I guess that's where she was. That's the first column. And then the emotion or feeling. She felt helpless. She felt hopeless. She felt ashamed. And so the negative automatic thoughts were, I'm a burden. I can't do anything for myself. I should just die. Evidence that supports the thought. She did disrupt the lives of her family members because they're having to provide care. So maybe there's some burden to them, but that's probably the only evidence that we could have come up with. Evidence that does not support the thought. Her family desperately wanted her to move in. They're happy to help. She's not helpless or hopeless, or I guess she's feeling hopeless, but she's not helpless. She, very much can figure this out. An alternative thought could be, wow, this is a complicated shower. Let me, work with my family so that I can, figure out how to do it for myself. Emotion or feeling should be, a feeling of empowerment, hopefully some calm or relief. So that would be an example of how you would use a CBT thought record. All right, next slide. Exposure-based therapies. So the most commonly used one is a prolonged exposure therapy, where these are time-limited, evidence-based series of sessions that cover breathing retraining, education about common physiological reactions to triggers for trauma, and then a processing of trauma with varied exposures. So these can be imaginal exposures, where somebody's imagining, combat veterans are, very studied, and these therapies have been used often for them. So imagine you're back in the situation, and that's an imaginal exposure, and walk me through it and tell me exactly what you're seeing. Tell me what the environment smells like and sounds like and what you're seeing. An in vivo exposure. So if someone had a trauma at, on a certain street or in a certain restaurant, let's go to the neighborhood where that restaurant is. Let's, see if we can get closer to the block, those types of things. And then now this is emerging, but they're doing more and more virtual reality exposure. So Again, it's mostly, not in our population, but in combat veterans, simulating real life combat, and they're wearing, these devices, and then, have a therapist there with them, monitoring them physiologically and helping them to bring down their physiologic response to the trauma. Okay, and this is just a worksheet. It was pulled from, there's a CBT for fear of falling for older adults, because many older adults who experience a fall then become very anxious and panicked about walking, which actually makes them at higher risk of falling. So there was a modification to kind of the CBT and exposure worksheets. And it's one that I actually used with Rachel, but I think it's a useful example of how somebody could modify these worksheets and make them useful. So it's just 4 prompt: remind yourself why this is important, remind yourself of your capability, remind yourself that you can handle anxiety, and remind yourself of what you need to do now. And then the person is supposed to, in the fear of falling one, take a step or take multiple steps. In my example with Rachel, remind yourself of why this is important. I want to be able to shower by myself. Remind yourself of your capability. I've showered by myself my whole life. Remind yourself that you can handle anxiety, just that. And then remind yourself of what you need to do now. And we had, a, thing with prompts of, turn this dial first, turn this dial second, turn this dial, whatever it was, to march her through. So she would go through that exercise. And that was kind of how we got to the exposure component. All right, next. So EMDR, eye movement desensitization and reprocessing. So there, everybody always thinks of it for the eye movements, but there is a CBT and exposure therapy component to this. It's a very comprehensive type of psychotherapy for trauma. But then there are these saccadic eye movements during the exposure. So how it works is the individual imagines the traumatic scene, focuses on cognition and arousal. Therapist moves 2 fingers across the person's visual field and instructs the individual to track his or her fingers. And then this sequence is repeated until the anxiety decreased, and then the person is instructed to generate a more adaptive thought. So the eye movements are used to engage the client's attention to an external stimulus while the client is simultaneously focusing on internal distressing material. And the eye movements are an example of what's called dual attention stimuli, in which the client attends to both external and internal stimuli. And so the key element in the effectiveness of EMDR therapy is this dual attention. So the client's ability to simultaneously be aware of their present safety, positive personal qualities, positive interpersonal interaction with the therapist, their strengths, while also accessing disturbing traumatic memory. Okay. So just in terms of the evidence base specific for our population, older adults, there are no randomized controlled trials, which are the gold standard, studying prolonged exposure, cognitive processing therapy, or EMDR in older trauma survivors. Again, it doesn't mean these types of treatments wouldn't be effective. It just means we don't have, the data to support it as robustly. There have been several randomized controlled trials that have shown benefit in older adults. They're fairly small trials, and they use really a CBT type model where they involve a biographical reconstruction of the person's life and the trauma, and then with the therapist involve a cognitive restructuring where the person marches through the events that happened and see where there are cognitive distortions and where they can fix them. Or substitute them with more adaptive, realistic, objective thoughts. So those have been shown in an older patient population to be effective. And then one of the big things is there have been a number, so there's a big question with older adults, because there has been some expressed concern that a trauma-focused treatment may be harmful to older adults due to the potential to increase physiological arousal among people who have comorbid physical conditions. So, there's theoretically somebody could be worried, could you put an older adult at greater risk of a heart attack or stroke if you're increasing their blood pressure, increasing their heart rate? What if they have chronic obstructive pulmonary disease and difficulty breathing? and they start to have a panic attack where they're having more difficulty breathing, could this put them at greater risk? And so this was a question. So there have been a number of case studies on variants of exposure therapy that do just that. They, evoke a physiological response where heart rate's increasing, blood pressure's increasing, but within a safe environment so that you can, basically learn to better control that physiologic response. And, so this was the question. Is it harmful to older adults due to the potential for physiological arousal among those with comorbid physical conditions? And 11 case studies using exposure therapy had a good response, and then there were 2 where there was an increase in symptoms prior to improvement. No study reported long-term adverse physiological or cognitive effects. In these studies, there were older individuals with a heart condition, dementia, comorbid major depression and panic attacks, so they did have comorbidities. And so, I think because of these case studies, there's, they suggest that exposure therapies have been shown to be safe and effective in an older patient population. But if clinicians feel uncomfortable, they can take additional precautions such as monitoring health comorbidities and working to coordinate with primary care physicians if there's a greater concern. And one other thing, just to say about that, just special considerations for assessment and treatment in older adults. If somebody has a dementia or major neurocognitive disorder, for some, it can lead to the exacerbation of trauma symptoms. And so for people with any sort of cognitive issues, but really all people I do this for, it's helpful to unfold trauma treatment slowly, to carefully track the impact of the treatment on functioning. So, I very much, when I'm, in the case of Rachel, I didn't want her to get much worse before she got better. I felt like this is a crisis situation in a 93-year-old woman. We want her to be functioning in her daily life and going very slow. So begin with education about trauma and then move to consider how to improve daily functioning. So for example, treatment can, incorporate use of calendars and checklists and step-by-step breakdown of tasks and involvement of caregivers and family members. And in addition, and I think, this can be a helpful place for E-MDT members and coordinators, it can be beneficial to provide education to family members, caretakers, and even medical staff. So the case, Rachel, it was strange timing, but she, for only the second time during the time of my treatment, was medically hospitalized this week. And I was in touch with all of the people on her treatment team, and I'm in the process unsuccessfully, but of trying to advocate for them to loosen the visitor regulations, because she's only allowed to have people from 10 to 6 because she doesn't have COVID, but she has a flu. And she's developing a lot of these same PTSD symptoms. So I'm, talking to patient services on her behalf. I'm talking to all of the treatment team members. I'm trying to get them to loosen the restrictions so that she can have trusted members of her family stay with her overnight while she's in the hospital, or at least a caregiver, because she's, going to decline. She's already, it's a sad circumstance for her, but, so those are things that I think E-MDT coordinators can think about, what systems of care is this person interacting with? How is it going? And when they're not going, is it not a trauma-informed care? Can there be modifications made? Can we advocate for this person? Can we help to educate the people that they're interacting with about, that yes, this looks like, this person is just aggressive or impulsive, but it's a symptom of trauma. And so we've recognized that if you interact with them this way, there tend to be better results. And one other thing I just wanted to mention about modifications for older adults is that for older adults, there are a number of sensory changes. So changes in vision and hearing, you want to address them, but even more so in people with trauma, because often these dissociative reactions where you're hearing things or seeing things that can be associated with trauma can be made much worse if people have visual difficulties or hearing difficulties. So it's important to address those that are normal in much of aging. And then also pain is a big thing. to address, because pain is very, very common in an older patient population. And then much more so, there's a robust association between chronic pain and PTSD. So to, address pain, to also make sure that the people addressing the pain understand that there's, a psychic pain as well. And so not to over medicate in these circumstances. And I think this is my final quote from The Body Keeps the Score. After trauma, the world is experienced with a different nervous system. The survivor's energy now becomes focused on suppressing inner chaos at the expense of spontaneous involvement in their lives. These attempts to maintain control over unbearable physiological reactions can result in a whole range of physical symptoms, including fibromyalgia, chronic fatigue, and other autoimmune diseases. This explains why it is critical for trauma treatment to engage the entire organism, body, mind, and brain. Okay. Anna?
So let's have folks use the chat as well, because we're still having some issues with the polls, but feel free to answer this question in the chat just as before. Not seeing a lot of chats going on, but I will keep an eye on it and we can keep moving.
All right, so just a couple notes about Rachel, the case, to close it up. She had seen a Freudian psychoanalyst and an EMDR specialist without benefit before coming to see me. My hunch is that it was open-ended. They were both very focused on her early trauma. She did not want to talk about her early trauma. She wanted to talk about the here and now. And that is common with older adults. They don't want to focus on the past. They want to live their life as effectively as possible in the here and now. And often they come and they mean business. And so she was like, I need to figure out how to use this shower. I can't depend on anyone. And so we addressed that, but slowly and over time. I had discontinued her antidepressant because she was having side effects. I collaborated extensively with the family and her primary care provider. The primary care provider diagnosed GERD, and that actually gastroesophageal reflux, and that actually helped her a lot with some of the anxiety once treated, because she had difficulty differentiating between the reflux and some of the anxiety symptoms. We worked on breathing techniques to manage the aerophagia. That was the collection of air in her stomach. And then supportive trauma-focused strategies with modifications over time. Again, these were prompts throughout her shower, different types of supports. She trained me a lot about how to create a safe environment. One time I complimented her on her sneakers. That's when I learned about how, her appearance, she was very caught up in her survivor guilt. I never again complimented her on anything that she wore or her appearance. So you'll get trained by people over time how to make them feel safe and pay attention to those cues and, do what they say. And in exposure therapy is helpful, but focused on optimizing independence and the appropriate use of supports, and home modifications can be very helpful. And I think there's one more slide, just takeaways. So most older adults have experienced a traumatic event. A coordinator can address their team's needs around trauma therapies as it pertains to the cases being discussed and provide a lot of psychoeducation. Symptoms of trauma often emerge or reemerge in late life. Trauma symptoms in late life are under-recognized and frequently misdiagnosed. Not all trauma leads to PTSD, but trauma symptoms are common, varied, and often severe in late life. Older adults can benefit from trauma-informed care and therapies, and comorbid trauma and cognitive or medical conditions may require a modified approach. And that, I believe, is all I have. I don't know if anyone has questions or comments or their own experiences.
While we're waiting for any questions that do come in, I am going to drop a evaluation link in the chat, just so we have that little time for everyone to fill out. This is just for feedback purposes. So That should be in the chat, and you'll also get that in our follow-up email as well.
I just wanted to say thank you. I think this information was incredibly helpful. I do a little bit of training for, I've done it for like our DA victim advocates regarding the trauma-informed advocacy. And you brought up some better ways of getting some of my points across. So thank you.
Oh, well, thank you. I'm sure I would learn a lot from your presentation too. I'd love to see it.
Caitlin, just because we have the opportunity and the time here, some things that we get into the National Center around neuropsychologists and victims is how do you engage within the E-MDT, your neuropsychologist? I know you participate on the Queen's team. We had the pleasure of working together in the past. So if you can just speak to how you were utilized on the team and what are some like helpful tips to engage your neuropsychologist?
Yeah, I think, you know, one of the things, and I know in each place it's so different, but one of the, tasks that I frequently am asked to do is to read the evaluations that are done on the victim and kind of read between the lines. So help to interpret, what does this actually mean and what could this look like in person and how would it interact with, legal implications, et cetera. So with questions of capacity, with questions of diagnoses, often, somebody has a diagnosis of, schizophrenia, but they're not taking any medications for schizophrenia. And the report doesn't necessarily, look like somebody who you would expect to have schizophrenia. So trying to make sense of that. So that's one way. Another way that I really enjoy and that's useful is sometimes an E-MDT coordinator will prompt me before we're meeting and say, for one of the recent ones was, the alleged abuser has a diagnosis of Huntington's disease. Can you, prepare to just give us a 5-minute spiel on, Huntington's and, what that may look like and what the course is and how that may, impact both the alleged abuser and the victim. And so if there are any, neurological, psychological, or medical issues that a coordinator knows in advance, is going to come up, I think it could be bring the case to life to have just some background information. And if you prompt that person who's on your team before, they can, throw something together that's a little bit more thoughtful. So that's a big way. Sometimes, in the, dynamics of, family systems, a neuropsychologist or a psychiatrist can be helpful in that. I think, sometimes in thinking about all different health issues. So, often we'll try to determine how vulnerable is this older adult really according to their, medical and psychiatric comorbidities. So if I hear that somebody has, diabetes and a history of a heart attack and a history of a stroke, and we don't know what their medications are and they're not getting them regularly, a neuropsychologist or someone may say, hey, that's a huge risk to them because we already know that their poorly controlled medical issues are, increasing morbidity and mortality. So to, help to prompt people to get in, somebody in the house, like a, visiting nurse to make sure that they have their medications and are taking them appropriately. Those are some of the most common things that I wind up talking about and thinking about with people.
Thank you.
Do you do any trainings for law enforcement or prosecution?
I do not. I would love to know what you do, and I think it would be so useful and interesting. We do have law enforcement on there, and they are, uniformly in the Queen's group. They're uniformly so thoughtful about this. So I imagine that they do get wonderful trainings. They're informative about what they can and can't do, but they're definitely thinking about how to do it well and thoughtful. So I'd be curious what trainings you do, and I'm guessing that they're getting trainings, but I myself do not.
No, I don't train. Well, I will be doing a training for our prosecution, our city attorneys, in June around World Elder Abuse Awareness Day. But I just think, victims across the board, no matter the age, that trauma-informed knowledge is so important because of the unexpected reactions. We have that expectation of what victims should look like, how they should behave, and what we think that they should be going through. And when they don't respond that way, I always get concerned about how those cases get handled. So I just think you have such a great depth of knowledge, and it'd be wonderful if you had the opportunity to share that with people that are not necessarily doing the social work piece, because I think for most social workers, we get that, we understand that, but I think people who are not on that side doing, also interacting with our older adults, it's helpful for them to understand that.
Right. Yeah. No, I think that I agree with that.
Any other questions? I do see that some of the participants dropped off as we finish the presentation, but do we have any other questions?
It's good seeing everyone and seeing some familiar faces and some new ones.
Thank you, Caitlin, for your time and your wealth of information. We will share the slides, and this recording will be available at the National Center. So please feel free to access it if you would like to move further. If you need connection, just let us know. Again, this training will be available. The recording will be available, and we will send out for all people who registered the training slides. So thank you, Caitlin, and thank you everyone for participating today.
Bye. Good to see everyone.
Yeah.